Thank you very much for Philip Brookman for this invitation. I think it's a really impressive meeting. I had a little bit the fear that it would be a very pharmaceutical-driven meeting, but I really have the impression it's really people who know, who are concerned also by the subject, and I'm happy to be here. So, eliminating hepatitis B and C. Let me just make a small comment to you. I think it is crucial to look where the people come from. I'm very concerned by this because I work in a prison, Chandolan. In Chandolan, we have up to 115 nationalities per year, and we really focus the region and the origin. If someone comes for tuberculosis control from the east, from Russia, it's very different. It's the main risk factor. And for hepatitis C, you will see there is also regional differences which you have to consider when you see a patient. So I thought presenting you just very briefly what is happening or what is prison in Switzerland, talk about some risk factors. I just chose two. I could have talked also about a toothbrush, because toothbrush in prison, in overcrowded cells, you have 5 people, they have all a blue toothbrush, and you can imagine how easy that is mixed in overcrowded cells. Or about razors, same color. It's not voluntary, but it happens that the people exchange these devices which can have hepatitis C on them, and we know that hepatitis C can survive outside the body a long time, up to several weeks, and this is a very high risk in such environments. So in Switzerland we have 3 called Concordat, 3 regional organizations to try to manage prison, but in reality we have 26 cantons and we have 26 different prison systems. We have only 4 cantons with independent healthcare in prison, which is Geneva, Waadt, Valais, and Neuchâtel, and all the others are dependent or mixed systems, so the doctor who is under the direction of a prison governor or of the justice or prison administration. And this has an impact on quality on healthcare. This is undeniable. Then we have 109 prisons for about 6,800 prisoners. This is probably the world record. So we have tiny prisons. In Geneva, just we closed recently a prison with 7 inmates. Impossible to have a professional healthcare service, social service in these small, tiny prisons. It's very good for the contact of the families. They are very close to their families. But we need also prisons which are a little bit more professionally managed. And I would consider the ideal size for prisons is around 100 to 200 or 300 prisoners. This is the perfect size and a human size, and also professional services can be provided. Otherwise, we have this male thing. It says the richest men or the richest people in the world are males, and the poorest one also in general males, and they are concentrated in prisoners. There's a whole concept about the weaker sex, these people who have also certain political impact now more and more in populistic parties. So the good news is that imprisonment in Geneva, in Switzerland, is not increasing in the last years. We have still in the capacity in gray, it's still increasing, but the number of prisoners overall is stagnating, which is good news, because there are other countries like France where it's steeply increasing. Geneva is the canton where it's also very much used imprisonment. And we have other countries, a lot of countries now, the Scandinavian countries, Germany, Holland is very impressive. They decreased the prison population from 16,000 to less than 10,000 in the recent 8 years. And this is a very good news for human rights, I would say. One risk factor is tattooing. And just to make it short, there's nothing done about tattooing. This is a very, very high risk in prison. I know one single safe tattooing project which is happening in Luxembourg. There were some in Canada, but they shut them down for economical reasons. And there's absolutely nothing happening in Switzerland. A colleague of mine requested someone who was tattooing himself to describe what has happened in Belgium, how to do this. So these machines in general, they survive 10 days in a prison. And when you have such a machine built, and you might be punished if it's discovered, you will tattoo everyone you get who is interested by it. And as you have a lot of time in prison, you can imagine tattooing is happening in big cells, overcrowded cells, in wards. A lot of people get tattooed with the same ink. And the ink, to produce the ink is, in general, they burn plastic and get everything which is somehow coloring, hugely toxic, adding pencils. I asked some of my informants, my patients, how they do this, and it is a high risk, very toxic, and hugely dangerous practice for hepatitis C tattooing. But nothing is done. Nothing is done. We have between 5 and 60%. We just made a recently systematic review on this topic of people experiencing incarceration. They report receiving a tattoo in the prison. Okay, different countries, different prevalences. Australia, there's a study, 41 with a tattoo done in prison, 27% reported also use of needle, and 42% of non-sterile ink. That's what they reported, and I think the reality is even worse. When we come to addiction, we have some prevalences in the country. This is a quite old slide, and I think, for example, for tobacco, now we're more around 26% and not 30 anymore. But in prison, we have much more. We have really much more. This is data from Geneva. It goes up to twice, up to 10 times more, or even higher when it comes to people who say that they experienced the year before the use of these drugs. And needle and syringe exchange is also a very big issue in prison. For Australia, I think you come from Australia, that is a huge fight since I know. I work now since 10 years in prison. Only about 60 prisons in the world have a PNSP. And this is a shame because all the evidence goes in the direction, and for some reasons, which is mostly emotional, non-scientific reasons, this is just blocked. Here in Zurich, you don't have a PNSP. There are some cantons in Switzerland who have it, and some prisons, but it is not spreading, even if the recent epidemic law, it is not the law, it is the application of the law, says now PNSP must be offered in prison. And nothing happens since 2 years now. We know that injecting in prison happens. In general, it happens less than outside. But if they inject, they have huge sharing practices, very dangerous practices. And that's not only for Hep C, it's also for HIV and all other illnesses which belong. So there were, Switzerland in Hindelbank and Oberschöngrün were pioneers, worldwide pioneers. A doctor said, we do it outside, let's do it also in prison. And they started the program, it was evaluated, and they have these machines now. You put the syringe in and you get a sterile new out. We have opted in Geneva for this hand-to-hand exchange, which has the advantage to have a contact with the person who can also provide prevention messages, but who has the disadvantage of you have to somehow declare yourself that you are a drug user, and this is a quite difficult step to do depending on the prison environment. And the evaluations go all in a good direction. There is no increase in incidence of HIV, H and Hep C. Needle sharing strongly reduced in general. Drug use is not increased, and injecting is not increased overall in these prisons where the PNSP happens. And despite of this, and we know also that it prevents HIV infection, there are no negative consequences on the prison environment, no increase of drug use, drug injection, not used as a weapons, never used in a prison where PNSP happens. It was used as a weapon. This is one of the major threats in general, these are the groups of prison officers. And it facilitates also referral of drug users to drug-dependent treatment programs. So despite this, we have this situation in 2016. These are in gray, clear. There are countries without needle exchange programs in the community or neither in the prison. In red, you have countries where you have it in the community, but not in the prisons, for no reason, no scientific reason. And in gray, dark, you have these countries where you have in some prisons a PNSP. World Championship is Spain. I will come later back to Spain. They're doing really a tremendous work when it comes to prevention and harm reduction. And as you know, anti-Hep C prevalence, there is a sort of degrading prevalence. It's more prevalent in the south of Europe, especially in Italy. And when you look worldwide, you see the Hep C in injecting drug users and with prevalences which are extremely high, sometimes up to 80%. Or even higher. So what happens in custody? In custody, it's extremely inhomogeneous. It depends really on the composition of the prisoners. If you have a lot of IV drug users, then you will have a lot of Hep C and other illnesses. This is, for example, in Portugal, they considered that there were so many viral diseases with very expensive treatment in the prison, and that was one of the main arguments to change the criminal procedures and to have alternatives to imprisonment for these people who are ill, and to change so for a crime related to drugs, you're not anymore sent to prison, you will be managed in a community setting outside the prison, and so they managed to decrease the prevalences in the prison for Hep C and HIV. Still, the prevalences are extremely high in the different countries. We have analyzed this some years ago, had about 7%. You have incidents. There's one study in Scotland, they found 18% per year of incidents, so yearly infections with Hep C. And in the US, and this is extremely important for public health, they estimate that 29 to 43% of all the Hep C population goes through the prison system each year. So prison is probably the ideal place to identify and to treat and to eliminate this illness. But we have important barriers for the treatment of non-interferon treatment, the DAA. First is the acknowledgement of the problem. Prison is managed in general by justice or by prison administrations. They don't know a lot about illness or about health, and they think they are the better managers for it. Therefore, they try to keep it because they want to control everything. This is for historical reasons, and there is a really urgent way to urgent need to first make more research. We don't know what happens. We don't know the prevalences in the prisons in Switzerland, one of the richest countries in the world. We don't know well the risk factors for Hep C in prisons, but we can imagine. I think no need to replicate every study. But the prevalence and incidence data are absolutely needed to build up a focused program, and this have to be done in collaboration with the main clients, which are people who are infected with Hep C and living in prison. So people who live in prison should be always implicated and integrated in these programs. Then we have an insufficient collaboration with public health. So I really welcome the work of Claude Scheidegger, who is really for Swiss hepatitis, doing a lot of work to bring people together around also prison health and Hep C, but it is very difficult. There's a lack of knowledge, and there are also implicit mechanisms. For example, I don't screen for Hep C. If I don't screen for Hep C, as the budget for prison health is within the prison administration, I don't have to pay the treatment. If I don't identify, I don't have to treat. And so this is quite perverse and happens in Switzerland. And therefore, there must be a much stronger implication of public health and of the cantonal health services, public health services. And what we have today is insufficient screening, lack of will of the healthcare providers, but also of the managers, of all the stakeholders. The prison organization is difficult because if I set up, for example, a prevention program, for example, on tattoo, this takes time. This is important to put energy and human resources in it. If there is a sort of major security issue happening, we had a murder case some years ago, and I can tell you all the programs which are not essential for management will be just put on ice a certain time. So, and then we have these payment models. Here in Zurich, for example, each prisoner has to pay 5 francs to see the doctor. 5 francs to pay 5 francs if not everyone has work in prison. In pretrial prison, in general, you don't have work. So you pay 5 francs and you have no income. And if you have income, the income per hour is about 2 francs. So imagine your salary and what you should pay to see your doctor. This is total nonsense. That must be for free. Healthcare must be for free. International organization. The UN just published in 2015 the UN standard minimum rules called Mandela rules, and they say healthcare must be for free. And if you don't have it for free, public health in prison does not happen. Okay? And there are very strong movements here in Switzerland now to pay the prisoner. They defined treatment, healthcare costs are private costs and not state responsibility, and other costs like housing, eating. This is state responsibility, but they just defined 2 years ago healthcare costs are private, and this is an error and really a threat on healthcare. And then we have this problem related to the high cost of the treatment. Still high cost, even if it's about 5-6 times less than some years ago. And I just wanted to make a very short point, but I will run quite quickly through. I think you know, or some of you know the problem and the solutions, and you will find it. I think these slides will be on the internet somehow. So screening and treatment. Okay, we have, I told you about the problems. We lack screening, we lack epidemiological surveillance, we lack what happens in prison today, and we lack access to treatment for everyone. That's so simple as it is now. There is some access to treatment. I think there are some best practice models in prison. I'm also a member of the Council of Europe. I visit in all the 47 country states in all geographical Europe prisons and police, and we have access to every place. And I can tell you, I just came back from Catalonia. If you once want to describe a best practice model, what happens in terms of epidemiologic surveillance, integration of public health before imprisonment, in prison, and afterwards, this is absolutely fantastic what they do, and I think they have the goal to eliminate EPSI from the prison by 21. Okay, so it's really extremely well done, and I think this must be also to be highlighted, what they do in a country which has a major economic crisis, and why are we not able to do this here in Switzerland, for example. Okay, the pricing, I don't want to spend a lot of time on this, but the pricing for Hep C is one of the major problems. And when I was recently in the Czech Republic, when I talk to the government and tell them, look, there are, for example, buyers clubs, we get the treatment in a, well, you are in, Arut did this, are the pioneers here in Switzerland, to get the treatment for some $100 in a very secure way. Then all of a sudden they get very interested in this. And there is cost-based pricing for medicaments, and there is value-based pricing, okay? So the costs are in general not very low, not very high. Value priced is different. And for example, in Geneva, we did this study to see about the sustained viral response of Hep C treatment. What are the costs of the treatment for Hep C in Switzerland? And this correlates perfectly. And in the US, it's even worse, let's say. And this is a huge threat to access to treatment for everyone. So there are strategies to make the treatment more accessible, or let's say at least at the more accessible price. And one thing, some people even travel to Egypt, stay there 3 months, and they treat their hepatitis for very low price and come back. And there's also this buyers club, and we just think about to do it, or we just started actually, to do it in Geneva at the university hospitals. Because in the prison where I work, 2/3 of the prisoners are without health insurance. They are these sans-papiers, the people who fall out of the system, and the hospital has to pay fully for them. And if there are all of a sudden 100 people you have to treat for Hep C, you can imagine the threat on the budgets. So this comes from this movie. I really recommend it. I saw it recently with my team in the prison healthcare. And just go through very rapidly these difference between patent rights and patient rights, to tell you that there is by law the possibility for each individual to import for your own use the treatment. This is written in German and in French in the Swiss law, is permitted. And based on this, a buyers club, you can import treatment for personal use, which is perfectly equivalent. And you can, for example, this combination, which is for all the 5 genotypes, which will cost about $200 for your personal use. This is a possibility today we have in Switzerland. And this might be considered for at least patients who have no healthcare insurance. All the others can decide for themselves if they go through the healthcare insurance or if they do it on their own. And we didn't talk about a huge barrier in access to healthcare, which is the franchise. So you can have up to 2,500 francs of franchise and for your healthcare insurance, and these are the 2,500 francs which you have to pay off your pocket in the beginning. Okay, to finish, just to tell you, and I have I think there is no doubt that prison is a high-risk environment for Hep C and must be much more in the focus, I think, of these strategies. And it is not happening. It is not happening until now. Public health should discover this place and make more important strategies to know what happens and then screening and treatment. It is also the ideal place to identify and to treat Hep C. And these barriers, they exist. It is around financing. It is around rapid testing. Maybe we can discuss about it. It's about quality of healthcare in prison. When you talk about independence, I think the quality of healthcare is different if you have in an independent system like in ours, for example. We were the first in the world 50 years ago to have it in the outside the justice and prison environment, prison management. So to be attached to a hospital is very different for a doctor in terms of implementing public health, what makes sense in terms of public health, and not so much under the threat of economic problems. Then the confidentiality is also a very important thing. A lot of prison doctors are pressured to give out the names of persons who have infectious disease to protect the system, and this is a very bad strategy. But if you have a conflict of interest, difficult to resist. And then the whole cost management, I talked to you about it. And we need the more implication of public health in the prison healthcare, and to leave you with this WHO sentence, good prison health is good public health. Thank you very much.